Hi there, it's Christine Rogers again from the University of Cape Town. This lesson is about managing patients with functional components. Even though it's a reasonably short presentation, it's one of the most crucial parts of dealing with patients with dizziness and vertigo. And it's a particular passion of mine, so I hope to get you feeling enthusiastic and to help give you the skills as to how to actually start negotiating conversations with patients with functional components to their dizziness. So let's get on the same page in terms of what functional means. It means different things to different healthcare professionals. Physiotherapists' idea of functional is completely different from the sense in which we're using it. In this sense, what we mean by functional disorders are bodily symptoms and disorders which are genuine, they are real, but they're not necessarily related to a defined disease process. The term functional is absolutely not the same as psychogenic or psychosomatic, and note that the use of the term psychogenic is often perceived as quite abusive by patients, so avoid that and use more neutral and transparent terminology. So functional diagnosis suggests that rather than a structural disturbance in the nervous system, where a biopsychosocial model is essential in understanding the nature of the disorder, we're actually dealing with a problem that is primarily potentially reversible. Functional disorders are not exclusively a developed world problem. They actually surface across the world. They're present in every medical speciality, and they have different names depending on different specialities. Irritable bowel syndrome, for instance, would be something that's common in the gastro world. Things like a globus hystericus is the functional disorder that's seen by ENT. And it's also not a new issue. And when we start tracing the evolution of functional disorders, they were really well accepted at the end of the 19th century. And then somehow, I think probably with the advent of Freudian psychology and so on, that actually we lost that original kind of nuanced definition where it is looking at the relationship between mind and body. And when you're dealing with patients with functional components, that's absolutely where you need to situate yourself. So you need to be open to this. So I love this illustration. I think it's really nice. The balloons above the woman's head represent buoyancy, and that's what we want our patients to have, is to be resilient, is to be buoyant. The nervous system is the string that holds the connection between the mind and the heart. We need to know how to respond when the string doesn't function particularly well. So just take a look at this slide. I've given you the specialities here, and you can see that in a lot of the specialities that you actually have these functional disorders woven through their diagnostic criteria. ENT, I've already mentioned, a functional dysphonia, losing your voice, and there's no structural abnormality. Globus hystericus, which is this feeling of a continual lump in your throat, that feeling of the lump in your throat before you cry, that sort of feeling. Cardiology, palpitations, unexplained pain. Rheumatology, fibromyalgia, something that I see reasonably often. Infectious diseases, everybody has got something in terms of functional symptoms and symptom syndromes. And so we need to be adding the things that we see in our professions to the list as well. As we start this slide, I'd like you to think about your symptoms, any symptoms that you have had in the last 2 weeks. What about things like headache or abdominal pain, nausea, tinnitus, if in fact you believe that's a symptom? And then how many of those resulted in consultation with a healthcare practitioner? So I'm just going to stop for a moment while you just write those down. It's important to realize that not all symptoms are going to result in clinical problems. I mentioned tinnitus. For instance, tinnitus may become a problem for quite a sizable proportion of our patients, but it's context and belief specific. If you lived in rural India, tinnitus onset would be regarded as a blessing and a positive thing rather than the messenger of potential harmful illness. So bothersome symptoms are common. Think about how many people in this class probably wrote a symptom down on the piece of paper. So between 80 and 90% of adults experience symptoms of some sort at least every week to 3 weeks, so they commonly occur. There was a nice study looking at American participants, and up to half of the ones polled reported being bothered by headache. 40% of the respondents said they had fatigue. Up to half of them said they had pain, and interestingly, a quarter of them complained of dizziness, confirming what we already know about how common dizziness is. Finally, you should also think about the time course of the symptoms. And generally, the rule of thumb is that 90% of symptoms for which there's no clear basis are found to be temporary and generally settle on their own within about 2 weeks. So the purpose of this slide is to make you realize that there's a big difference between the presence of symptoms and the presence of disease. Symptoms arise from combined physiological, psychological and behavioral factors, as well as cultural influences and external factors such as compensation. I'm thinking of the many insurance and medical legal claimants that I see, and often just that engagement with that process actually governs the severity and the persistence of symptoms. So it's really important to realize that there are different drivers for reporting and experiencing symptoms. Up to a third of symptoms reported by patients in primary care and in specialty settings like the one where I work remain what physicians would call medically unexplained. In other words, there's no active disease process that can be identified after adequate investigation. And even when disease is present, there's a vast difference between the way patients experience the same disorder. So you can have 3 patients with Meniere's disease. For one, it's completely disabling. For the other, at the same clinical stage of the disease, it's not having that great an impact. So this is an important thing to realize, that patients engage with illness differently. And what's underpinning this variation is often thought to be due to psychological influences in the patient themselves. Again, even if the patients have significant or multiple diseases and comorbidities, the symptoms that the patient is telling you about may not actually be related to that, so the association may be coincidental rather than causal. So even though there is, I'm thinking of patients that I've seen with semicircular canal dehiscence syndrome, their main complaint is actually not due to the fact that they have small holes in their temporal bone. And it's very easy to chase the stuff that is readily definable, and this makes our patients vulnerable to iatrogenic issues. Good example of me saying that even when disease is present, the symptoms have a variable relationship with the presence of disease is hypertension, high blood pressure. This is known as the silent killer. People walk around with high blood pressure all the time. That's why every time you go to the GP, the first thing they do is get the cuff out and take your blood pressure, because it's such a common thing. However, the symptoms of hypertension are often only described by patients after the diagnosis. So these symptoms are things like dizziness, headache, weakness, and epistaxis, which is nosebleeds. So it's interesting, isn't it, this relationship between the presence of symptoms and help-seeking behavior. And you've got to also bear in mind the context in which you work, one of the contexts in which I work. I have a large population who are historically underserved by the healthcare system. These patients are often very stoic. The threshold before they actually report for symptoms of dizziness is fairly high. So they can be enduring real distress and significant disease without the benefit of professional help. At the other end of the spectrum are patients who visit doctors repeatedly in the absence of significant medical or psychiatric disorder. So they're help seeking a lot of the time, diagnosis seeking a lot of the time. Whether patients or not act on their symptoms or not is important in terms of escalation of healthcare costs, particularly in managed healthcare systems such as the NHI, which is going to be coming to us soon. So symptoms, as I've said, are the patient's subjective experience of their world. We as health professionals are trained to find a disorder that actually underpins these symptoms. And you can see, therefore, that from there, when we can't actually find anything responsible, it may be tempting to think that the symptom may not be real or of psychological origin. Unexplained symptoms and chronic symptoms are frustrating for both healthcare professionals and patients, and they're costly in terms of healthcare systems, as I've already mentioned. For example, over-investigation and repeated healthcare utilization. So let's continue exploring the contributing factors towards these issues. Studies on the general population at primary and specialized levels have shown that at least 1/3 to 1/2 of symptoms are medically unexplained. Even though I don't particularly like that expression, it's something that you can easily understand as terms of being there's no disease that can be found to be underpinning the presence of those symptoms. Reasons for this, for the high amount of patients for whom this is the case, is the frequent lack of objective findings on examination or on diagnostic testing. And this is something that's very common in the world of the vestibular patient. It's actually quite unusual that you see active signs, and even if signs are present on objective testing, it may be misleading. And I think I've mentioned this in other lessons in the overall clinical picture. Second, that there's a difference in terms of how clinicians evaluate and manage the same disorder. And so that leads to different tests and different treatment approaches, making it very difficult to actually pin down. Also, bearing in mind, again, with dizzy patients, you may have several different professions involved with care of the dizzy patient, and they may not all be coordinating with each other and practicing in an interdisciplinary manner. So you may have cardiologists on board, ENTs, neurologists, psychiatrists, psychologists, physiotherapists, even occupational therapists. So it's really important in dizziness and indeed in functional disorders that everybody is singing from the same hymn sheet. You all have to share the same outlook in terms of caring and truly supporting patients with functional disorders. Let's consider a moment the presence of more sophisticated diagnostic testing. And again, you'll see from other lessons that we have far more weapons in our armory in terms of investigating the dizzy patient than we had, say, even 20 years ago. And this is obviously a good thing. It's a particularly good thing with medical legal claims and what have you. But sometimes it's not such a good thing because you can have an increased number of false positive results, which may therefore be linked to error in managing non-specific symptoms. In particular, I'm thinking of things that you find on imaging, which are now called incidentalomas. So you get radiographic abnormality in an important percentage of the normal population, and then that can be attributed to be the cause of the patient's symptoms when it may not at all. And finally, although those are an important percentage but still reasonably unusual, what's not unusual is depression, anxiety, and somatoform disorders. These are the three most common comorbid psychiatric conditions in patients who present with physical complaints. And there's no reason to think that our dizzy patients are any different. At least 1/3 to 1/2 of all physical complaints are unexplainable. But what we do know is that depression may be diagnosed between 50 and 60% of the time. Anxiety can be diagnosed between 40 and 50% of the time, regardless of the symptoms. So in other words, every second patient that we see, at least, is likely to have either depression or anxiety or a double whammy of both. And in patients who are referred to specialty clinics, physical symptoms are unexplained in at least 1/3 of patients, 1 out of every 3 patients. So it's something that we have to engage with to be holistic, patient-centered, compassionate, and caring clinicians. Let's consider red flags for functional components. The first thing you have to acknowledge is that there's a strong relationship between the number of physical symptoms reported by a patient and the likelihood of either depression or anxiety. So the total symptom count is a powerful predictor. There are instruments that allow you to do this and has a much stronger relationship with depression and anxiety disorders than the number of medical disorders. In other words, patients with multiple medical problems usually only check a limited number of symptoms as bothersome on a checklist. They tend to focus on a few predominant complaints. The fact is that depression and anxiety are extremely common, while multisystem diseases are actually quite unusual in primary care, and they usually have other objective manifestations besides symptoms. So you need to be aware of the red flags, but also bear in mind that the minority, that's less than 5%, of physical symptoms seen by primary care physicians are acutely serious. And I find that clinicians tend to worry more about missing potentially sinister pathology than they do about picking up these more nuanced issues. In addition, only a minority of symptomatic people become true patients. Refer to the exercise we did earlier on in this lesson. And becoming a patient and that help-seeking behavior can be prompted by the severity of the symptom or its persistence. And as we've mentioned in other lessons, many patients arrive at a consultation because of symptom-related concerns and expectations. However, patients often don't volunteer these concerns or voice these concerns specifically unless they are invited to do so, and that often doesn't happen. Patients might be reluctant to reveal their real agenda because of embarrassment, fear of wasting your time, or they think that if you think it's important, you as the clinician will ask them, which often doesn't happen. So it's often helpful to ask, is there anything else you're worried about? Or is there anything particular that you wanted? Or is there anything that you think may be helpful? So we need to work on active listening. And the Kaiser Permanente Foundation, they're the ones for whom the writers of the 4 Habits model worked, and they pioneered good patient-centered communication in their organization. Estimated that in the 15 years since the publication of the 4 Habits model, in 15 years thereafter, we as clinicians only added 8 seconds onto the clinical encounter before interrupting patients for the first time. And we've discussed this in a previous lesson. And at the same time, if you decide not to interrupt, it only takes an extra 6 seconds of asking questions like anything else to complete the patient's agenda for the visit. Very interesting data there. So the graphic that I put on this slide is to remind you that you need to listen to patients actively, but you need to listen with your heart. This Chinese symbol says it all, and just to draw your attention, king there is actually the mind. So we need to listen with ourselves, we need to watch for anxious behavior in our patients, we need to give them our undivided attention. One of the reasons that healthcare practitioners dislike dealing with patients with functional disorder is because they lack the skills to A, identify them, and B, more important than that even, is how to have a transparent and clear discussion with patients about what exactly they are finding. So let's start off by looking at some of the labels that the literature have used to discuss functional disorder. First of all, purely symptomatic labels. So you have low back pain, for example. It doesn't really tell you anything about the cause, about management. It's just simply labeling it. And in our world, it's like a GP saying to a patient, oh, you have vertigo. Yeah, okay, and then? What about things like symptom syndromes, things like chronic fatigue syndrome? Now, we all know, and the literature tells us, that this too is at the interface of physiological and psychological issues. So why are we masking that by using a term like chronic fatigue or ME, things like that? One of my personal favorites is a non-diagnosis, where you tell patients what it's not rather than what it is. So here you're using terms like non-organic. Medically unexplained is a dreadful one as well. And you've got to bear in mind that even if you can't find direct cause, it may well show itself later. So why use terms like medically unexplained? So these diagnoses imply that there's a psychological cause that you haven't quite established yet. This is words like psychogenic and psychosomatic come in. Or that there's an unestablished disease cause that again hasn't shown itself. Now the psychiatrists and DSM-5, which is the most recent sort of manual by which psychiatric disease is identified, like terms, and the German literature again also likes this, somatoform. And the German literature particularly talks about somatoform dizziness, somaticization disorder. And this is one that is used. It isn't offensive per se, but I don't think it really emphasizes where the issue is and also the fact that it's actually reversible. So hence us preferring to use a term like functional. Functional, again, it's actually a historic diagnosis, and there's a strong movement in the neurology world to actually have this as the key word that we use to define these disorders. Then, of course, you have the official psychiatric diagnoses, which include things like conversion disorders, which I have seen, but very, very occasional. Dissociative motor disorders, things like movement disorders that are thought not to have an organic origin. Hypochondria, in other words, patients are exaggerating the severity of their illness. Again, you're putting intent on that. Factitious disorder, now here you're talking about deliberately simulating a disorder so that you obtain medical care. So examples of that would be things like Munchausen's by proxy. And these are potentially very, very dangerous disorders in terms of the opportunity for iatrogenic damage to patients. Malingering, now we need to be really clear here. Malingering is deliberate simulation of illness for clear financial or material gain. So for example, somebody malingering a hearing test to simulate hearing loss because there is a medico-legal claim after a head injury, or the patient wants a disability grant or something like that. Now I'd like to just caution you at this point. You can only use the term malingering when patients have basically admitted to you that they have been untruthful. You also have to realize that malingering is actually criminal behavior. It's fraudulent. So you are deliberately trying to do something so that you get usually financial compensation. So that's actually criminal behavior. And it's about knowing that there's intent. The patient deliberately did it. And I would actually argue that more often you are dealing with the other end of the spectrum where the patient's motivations are not necessarily apparent. And so I would urge you to use more neutral language when you are describing issues such as this. So let's bring the discussion to the world of the dizzy patient. On this slide, you'll see the kind of terms that healthcare practitioners dealing with dizzy patients use. You already know about a 3PD, triple PD at the top there. Its previous iteration, same disorder, was called chronic subjective dizziness, which was the term used in the literature for about 10 years. Clinicians often talk about some form of overlay, and here the implication is that it's a psychological overlay. I've already mentioned somatoform dizziness, functional dizziness, and then catastrophizing behavior. And to give you an example of catastrophizing behavior, if patients have had calorics done, for example, where they've actually induced vertigo and nystagmus, I often ask patients how it felt. And I always say that you get two types of patients. The first type of patient, they kind of go, oh, I thought I was dying. I'm never, ever, ever going to have that test done again. Please don't send me for that test again. And then the other half of patients say, yeah, I felt a bit dizzy. Why are you asking? Isn't that interesting? It's the same stimulus, and yet the responses to that same stimulus are polar opposites of each other, and just gives you an idea how a stimulus may or may not be amplified by the response to it. Okay, so let's just have a look. Reason we like functional, I've already mentioned that the term psychogenic has been used as a form of abuse. It's also often out there in the mass media as well. And patients, when they hear the term psychogenic, often read the word imaginary in its place. So they think that you don't believe them. It's also, as I say, extremely broad, it's non-specific, and it's used in different ways by different professions. So psychogenic could also promote doctor shopping, and that's what we don't want if patients feel rejected. So they're going to go from one clinician to another to try and find a different label. They don't feel accepted by their healthcare practitioners, and they carry on seeking examination, repeated investigations, and checkups. And so that's very burdensome for the healthcare system. If you use the term functional, it stresses the reversibility of the problem. Function can be improved with work. So it allows the patient to step up and take some responsibility for management of a chronic condition. It also, the term functional, better reflects the state of the evidence regarding the pathophysiology of these disorders. We're going to find with more and more sophisticated imaging that patients with triple PD, their brain actually just functions differently from patients who do not develop a triple PD. So if you use the word functional, it makes feedback much easier, it's much more transparent, patients are much more likely to buy in to the diagnosis, and if patients understand and buy in to the diagnosis, they're much more likely to take your recommendations for management. And promotes a language in which we can engage our patients and give a scenario in which to actually understand their disorder. It's also free from causal jumps and attribution, so it doesn't actually reinforce this dualistic thinking between mind and brain. It allows us to focus on the patient's reality and suffering without questioning its legitimacy or if the symptoms are really real. And that's really important. And I've mentioned before, one of the most powerful things you can say to a dizzy patient is, "I believe you." So just bear that in mind as well. Why is the identification of a functional disorder so important in both our own profession and other professions? Well, the figures are actually quite staggering when you look at it. Nearly half the patients who visit specialized otoneurologic units exhibit psychiatric disorders, nearly half. They're most significant in patients whose main symptoms are dizziness, complex forms of tinnitus, or sudden and relapsing sensorineural hearing loss. So it's a lot of patients. And if you don't identify and address the psychiatric components, they result in inappropriate treatment. Comorbid symptoms like reactive anxiety or depression may cause patients to have coping problems with their illness. So they're just doing things like help seeking when they should be therapy seeking. Furthermore, reactive psychological disorders can lead to severe impairment of daily life, so quality of life is often much worse for patients with functional disorders. And interestingly, the intensity of diagnostic and medical measures is often more in response to the severity of that comorbid or reactive psychological disorder than it is to the severity of the organic problem. So we've got this quest for zero defect, and I'm going to talk a little bit later about how prolonged investigations are often the worst thing you can do for patients. And in turn, the cost of the patient's healthcare goes up. So the presence of functional components is usually included very late in differential diagnosis or completely overlooked, which is why a diagnosis is delayed for several months or even years, or actually not made at all. And this delay has the effect of increasing the tendency of the dizziness to become a chronic disorder, leading frequently to people stopping work, severe impairment in the quality of their life, and high health costs due to repeated assessment as they continue doctor shopping. During the course of the illness, 50 to 70% of patients show dizziness symptoms after several years. In other words, these patients don't get better. Only 1 in 4 patients ever receives appropriate therapy. Very nice study by Sean and his group, and they did longitudinal studies looking at the psychological influences with dizzy patients. And in a reasonably sized study, over 200 patients, over 2/3 of the patients had an acute psychiatric disorder. That's a lot, 2/3, much higher than other researchers' findings. Patients showed higher emotional distress, worse intensity of symptoms, worse performance at work, longer periods off work, and also bear in mind the longer patients stay off work, the more difficult it is to get them back to work, just as an aside. They, as we've already mentioned, have more demands of medical attention and generally much higher stress levels than patients with just a vestibular neuritis or just Meniere's disease, for example. So really interesting there. And these findings have been upheld by other studies again and again. Again, I'll point out to you the chronicity of these symptoms. They persist at a 3-year follow-up. 2/3 of those patients continued to have dizziness, much worse in Sean's series than it was in other studies. A significant number of that same group had clinical anxiety, so that's something that a psychiatrist is going to diagnose, about 40%, depression in about 20%, and other somatoform disorders in over a third. A particular concern in this research is that in spite of intensive counselling regarding their condition, almost half the population continue to seek diagnostic procedures. So again, they're not moving towards a therapeutic lens. They're still at the help-seeking, diagnosis-seeking stage. All of those patients were referred for psychotherapy. Less than half actually pitched up. And that again probably was related to the high rate of non-resolution of symptoms. Some quite interesting studies. I've just pulled out one just to give you an idea of what's going on, but there are many, many more. And the song that is being sung basically doesn't change. So it's for us to change how we respond to our patients. So let's explore a little bit. If we can bring ourselves to accept that functional disorders exist, we really need to think about our role in terms of ensuring that these issues are not actually dealt with. And the first thing is that healthcare professionals are often very reluctant to identify and therefore manage these issues in our patients. So they often won't reveal it, they won't ask the right questions to see what's going on, and then they're very tentative and cautious about addressing the issue. This can be because they feel they haven't had adequate training, that their skills are not appropriate. They often say, well, I'm not a psychiatrist, so I just don't know how to go about this. But I'd like to argue that this is something that we all need to be embracing. The second thing is it's very seldom highlighted in the curricula of our training for various professions, and even in textbooks and research, it's often the sort of orphan disorder that is not actually discussed as much as it should be, bearing in mind how common these disorders are. So functional disorders have rather got lost in the 20th century, and hopefully it's improving as we are well into the 21st century. Because we were using imaging to actually look for disease. And that seldom in the world the dizzy patient actually allows you to make a positive diagnosis. So we created these patients with orphan diseases and orphan patients that are just not cared for at all. I think also we're more frightened of missing a diagnosis than we are of actually making a positive diagnosis. And finally, I think in some practitioners' hearts of hearts, they still doubt whether the patient actually has a real or genuine disorder at all. Patients with functional disorders are often perceived to be difficult, which is just untrue, and time-consuming, which is true. So these patients do take time. Something else I'd like to mention is often failure to manage patients with functional disorder is because of inability to manage our own feelings. Your clinician's reaction to the patient is very important. So you've got to think about the feelings that the patient is evoking for you. In primary care GPs practices, 1 out of every 6 primary care patients is regarded as difficult. In other words, patients who trigger these difficult encounters are 3 times more likely to have depression or anxiety disorder, or 9 times more likely to have a somatoform disorder. So if the patient is ringing bells for you, if it's making you feel uncomfortable emotions, this is probably why you are picking this up from the patient. I've given you a really nice reference for an article from a UK newspaper that actually talks about when she started engaging with functional patients. She was a neurologist and all she wanted to do was treat patients with so-called real disorders like Parkinson's disease and multiple sclerosis. And she talks about her journey of acceptance regarding her attitude towards functional disorders and realizing this is a really important part of her work and it's important to get it right every time if you can. So I've included this table from DSM-5, which, as I mentioned, is the sort of manual of the American Psychiatric Association, which they use to make diagnosis. So it's a criterion for diagnosis. And personally, I loathe this medically unexplained symptoms, but there you are. But this revision is an attempt to offer a common language with which to classify mental disorders. The category used here is somatic symptom disorder, a lot more neutral than medically unexplained symptoms, and it encompasses previous terms like primary somaticization disorder, somatoform disorder, and also hypochondria. Earlier versions of DSM used the term medically unexplained symptoms as their hallmark. This is problematic because the diagnosis is unreliable, and again it promotes this mind-body dualism that I mentioned earlier. In DSM-5, there are three main criteria. The first one is distressing and impairing somatic symptoms are present. The second one is the duration of the symptoms. They have to be present for longer than 6 months. They have to be associated with abnormal and excessive thoughts, feelings, and behavior, for example, catastrophizing, which I've already mentioned, anxiety, and illness behavior. And now the big change here is that much more emphasis has been placed on the positive features. In other words, you can identify features that allow you to make a diagnosis. The previous requirements of a psychological stressor being present and the patient must be thought not to be feigning have actually been removed from the new version. In the influential International Classification of Disorders in 2017, for the first time, functional disorders appear in the neurology section. And this brings neurology in line with other professions I've mentioned, such as GIT, which trains their specialists to deal with symptoms like irritable bowel syndrome holistically. So again, let's bring it home to roost in our world. What about the features of a functional dizziness syndrome? Well, the first thing is that you're going to see a difference between the objective findings and the subjective complaints. So in other words, your tests are often going to be normal. Anxiety is very common, but you need to reveal that during a careful case history. And we've done case history in some length, and when you ask for these questions during case history is very important, as well as how you ask for them. I always ask patients in whom I'm suspecting a functional component if the symptoms improve with distraction. So things like activity, are you better at work, and also alcohol. Often these patients improve with a little glass of wine, so I always ask about that. Exercise also something, if they improve with exercise, it's also a suggestion of a functional component. Note also the length of symptoms, the duration of symptoms, months or more, present on most days, no real triggers, and then finally often fear of falls without actually a history of falls, and usually you need the fall and then patients develop fear of falling.
So having discussed some red flags, let's zoom in now and have a look at features which would be very suggestive of a functional dizziness syndrome. The first thing to look for is complaints of dizziness combined with non-vestibular complaints, things like abdominal or heart symptoms, muscle weakness, pain syndromes, with the exclusion of headaches and sleep disturbances. The second thing is that symptoms often have a circadian rhythm. So patients are feeling okay first thing in the morning, and then often symptoms start setting in around after breakfast, mid-morning kind of thing. So that's quite an interesting thing. It's unlike other forms of dizziness, and there's more and more evidence to suggest that there is this definite kind of circadian rhythm to it. If patients complain of acute vertigo, during the examination. The first thing you must do is put frontal lenses on, make sure there's no nystagmus. If there's no nystagmus, then a vestibular cause is unlikely. Functional disorders of balance and gait show bizarre patterns such as excessive slowness, hesitation, fluctuations, improvement of Romberg testing with distraction, walking on ice type gait pattern, or sudden buckling of the knees. So watch out for all of these unusual issues. Social triggers, you always want to ask where symptoms are most trying. Here you're looking for things like space and motion discomfort, supermarket syndrome. Just be careful of things like escalators and door freezing, because that can be suggestive of Parkinson's. And then chronic unsteadiness following transportation, things like Marder-de-Baker-Mars syndrome, which is definitely higher grade. Those are functional disorders as well. And now the features that you would not expect as part of a functional dizziness syndrome. Things like frequent episodic descriptions of definite attacks of vertigo, and then totally symptom-free between episodes. So those are rarely functional. They're more likely to be issues like Meniere's disease and vestibular migraine. Presence of nausea and vomiting, always like to see this. It generally is very suggestive of an acute vestibular upset at the labyrinth, nerve or nucleus kind of level. Deviation of gait and falls is also suggestive of a vestibular disorder, whereas remember we said fear of falling but without falls is not. Dizziness associated with auditory symptoms like hearing loss, tinnitus or fullness is very suggestive of a peripheral problem. And then finally, as opposed to situational triggers, positional triggers are more common in conditions such as BPPV. Might be useful to be aware of the criteria for distinct panic attacks as opposed to anything else. And dizziness, the presence of dizziness in and of itself is not a key to help make a specific psychiatric diagnosis. However, dizziness is a component of almost all panic attacks and indeed many phobias. So a good question to ask when trying to get to the bottom of it, do you ever have times when all the symptoms come at once in a rush? Also, hyperventilating the patient in the clinic may induce a panic attack, so be aware. If the patient starts getting distressed, asking questions about, is it your kind of dizziness happening now? Is this what happens when you get one of your episodes? Would be important. So let's just have a look at the criteria. Chest pain, palpitations, pounding. Patients often feel one symptom starting, and then, as I said, they all come together in a rush, and then they start escalating, and the patient then has no control over them. Dizzy feelings, lightheadedness, faintness. Hot and cold sensations and sweating are common. Trembling, shaking uncontrollably, also very common during a panic attack. Not unusual to have patients reporting derealization or depersonalization. It felt like it was happening to somebody else. I was on the ceiling looking down, it happening to myself. That is quite common. It's also common in many other neurological issues as well. So don't, get too hooked onto that as a symptom. Very commonly, patients, if asked but they won't volunteer this, is that they feel like they're going to go crazy, completely losing control. They really think they are dying. These symptoms, I can't overemphasize how frightening panic attack symptoms are. You can't breathe. You really are in a complete state and you are unable to do anything to help yourself, so you often feel very vulnerable. So panic attacks are not to be laughed off. They feel very, very real. And then also in the background is persistent worry or changes in thought patterns for at least 1 month. Just a reminder at this point, I always say, and I've said in other lessons, there's a reason why we have 2 ears and 1 mouth. You've got to use the ears twice as much as you use the mouth. And and listen to the patient. If you listen to the patient, they tell you the diagnosis, they tell you what is wrong. And again, it's really, really important. And one's attitude and being open to hearing the patient is very important. So some tips about things to avoid. So taking a history is twofold. You get the chance to find out what's going on, and the patient gets the chance to feel unburdened and to gain confidence in you long before the diagnosis is discussed. So it's this dance between you and the patient. Patients have often had bad experiences with others, and the reasons for them having had bad experience include bad habits from the healthcare practitioner. For example, cutting the patient off before they have described all of their symptoms. Patients feeling dismissed or disbelieved, thinking that the doctor's on a quest to find some sort of psychological problem. So you can't have the patient thinking that there's this jumping to conclusions and that you're looking for something to hang the problem on. And also remind you that in many, many functional dizziness syndromes, patients don't have to have form, as I call it. So they don't have to have had previous functional disorders. This can be in and of itself. Ignoring the patient's attribution, not asking patients what they think is causing the problem. If you fail to give the patient a firm diagnosis or resources to read about afterwards. And finally, rushing the patient. Very important to avoid rushing the consultation and, importantly, the feedback. Let's talk about what you should be doing. One of my favorites is what we call drain the symptoms dry. In other words, you have to get all of the symptoms out. And we talked about this in the how to do a case history. Keep saying things like anything else, aha, go on, tell me more. Make sure you get everything out. And again, I always arrange my encounter with the patient so I get all of the physical symptoms out, every single one, and only start probing about anxiety and depression much later in the interview. I always ask about impacts. So I asked about things like fatigue, sleep, pain, poor concentration and memory. Incidentally, poor concentration and memory are very common in vestibular disorder. So if the patient answers yes to those, they are what they are. It doesn't mean one way or another in terms of arguing for or against a functional diagnosis. Fatigue and sleep deprivation could in fact be the main problem. Depression could be the main problem, or not. Ask about the onset and course. Remember there's triple TA. Our main functional dizziness disorder, triple PD, has definite timing that we can identify that helps you make a positive diagnosis. Ask about disability carefully. Describe a typical day for me. And very importantly, get the previous medical history. Get the notes if you possibly can. So the ICE system, which is asking patients about ideas, concerns, and expectations, that's a method commonly used in physiotherapy, is definitely taught to our students. We always teach this, but many other practitioners already in practice or who've been in practice for a long time may not directly be considering this in part of their clinical encounter. Asking these questions allows you to tailor-make the feedback and personalize the feedback, and then this discussion in turn becomes therapeutic. Does the patient want specific investigations or treatment? Ask about dissociation if you are concerned about a functional diagnosis. Dissociation is a collective term to describe the range of psychopathological processing that alters a person's level of awareness. The integration of sensory motor function, emotion, thoughts, memories, and identity may be abnormally perceived as a sense of disconnection. I gave examples of that earlier. I feel as if I'm watching my life unfold on a video, things like that. If patients get warning symptoms, then ask for probes like, do you feel faint? Then probe some more. Is it a feeling of having just got out the hot bath? Everything is spaced out. Don't worry about sounding silly. I often say the more detail I get, the more I get to know you, the more I can actually help you. Bear in mind that patients may lack the words to describe what they're feeling, and they might actually be worried that they sound crazy. So I call this my "how are you" question, and I never like "how are you" right at the beginning of the consultation, because patients always say, guess what, fine. You need to build up to this one, because these in the paler grey on this slide are the things that you are really looking for. So you may not directly question this. You might build up an idea about anxiety and depression by asking about a typical day, for example. And then you could say something like, if you're feeling low, is it worse? How does that affect you? And again, as I've stressed before, asking questions like this prematurely or in a clumsy way can be what I call anti-therapeutic, by raising the suspicion in the patient that you think it's all in his or her mind. So what do patients generally with functional disorder desire from you as a clinician? A really good feedback session. So the first thing is they want to be heard. And again, I love this phrase, to be heard and understood. Very, very important. To be heard and receive emotional support even before they receive the findings which may explain their symptoms. You want to get the investigations over with as quickly as you can. You don't want to have a disease focus when a rehabilitation focus will be more beneficial to the patient. Again, you need to balance the risk of an incidental finding which may delay or disrupt management. So you've got to be prudent about the investigations that you are asking for. Remember as well that even if the tests are positive, even if they are suggesting something, there could still be a functional overlay, and unless you address that directly, the patients aren't going to have the same outcome as if you ignore it. So very important there. When the diagnosis is clear right from the start, you need to start to give an explanation of a functional cause, and that you expect all of the investigations to be non-contributory. So you need to prepare the patients to receive no news. This will lessen the patient's anxiety and assure them that you're not relying on specialized and expensive tests to give a different answer, or that you have reached your diagnosis by a process of exclusion. Remember, we said at the beginning, this is an inclusive diagnosis. It's, if you like, a deliberate diagnosis. It's not just something after you've ruled everything else out. Telling patients that their workup was normal may not convince them that you've made the conclusion the right way. So when do you want to take it further? If you're uncertain of the diagnosis, or if the patient is uncertain of the diagnosis, even if you are. Some patients don't want tests, they actually just want your confident opinion. Other patients are only interested in the scanner's opinion, so you need to know. This is why asking is so important. Sometimes normal investigations can be helpful and actually promote recovery, so they can be therapeutic in and of themselves. They need to be carefully managed in terms of the expectations. And again, bear in mind that with dizziness, most investigations are actually unhelpful in terms of making the diagnosis, so your yield here is very low at the best of times. So some key points to remember as we move away from the beginning of the clinical encounter more towards the examination. Your diagnosis should be supported by key issues on the examination, plus the presence of a suggestive history, and not the absence of disease. Bear in mind that the functional issue might be an add-on to existing disease. So what are you looking for? Things like patients improving with distraction during a Romberg. This could be presented in a positive way. The diagnosis is positive and not negative. It's made on a bedside or clinical diagnosis and not because the scan was normal. The signs demonstrate the potential for reversibility. The signs also demonstrate the role of attention and the benefits of distraction. And can you see you can get all of this just from one test that historically is very weak in investigation of the vestibular patient. And therefore, because we know that attention and distraction can have a positive influence on your balance, it's a modifying thing, so it allows us to reverse this issue. Very important to be hands-on during the examination. Patients expect to be touched during an examination. horrified when a friend of mine got a really bad diagnosis of cancer in the abdomen, and she had had at that point multiple scans, bloods, and everything else. She eventually got fed up, and this was the first of about 8 or 9 doctors who physically examined her, who actually palpated. So it's really, really important. Hands-on touch is very important. Remember to explain what you're doing as you go along. Mention all of the normal findings as you record them, as this helps you improve the confidence and transparency in terms of the quality of your encounter with the patient.
This patient demonstrates several features of the psychogenic gait. The first thing to note is that the phenomenology of the gait itself does not fit any particular pattern of a known neurologic diagnosis. Second, the bizarre movement seen here in this odd rhythmic bouncing and the flailing of the legs in his steps. Finally, altogether these movements are actually somewhat acrobatic and require more balance than a normal gait.
So let's talk about the pitfalls of giving a diagnosis of a functional lesion disorder to a patient. Remember, if it's done properly, the diagnosis and the explanation can actually be therapeutic. This is the second dance that you're going to do with the patient in terms of the start of the healing process that's going to continue each time you see the patient. So you need to make definitive statements about what you think is wrong with the patient. Keeping patients in what I call diagnostic limbo, just leaving them up in the air, is simply not fair. If you manage tinnitus, for instance, this is the equivalent of that turning around session with the patient. This is your moment to move patients from diagnosis seeking to therapy seeking. So let's have a think first about why things go wrong. Just why do we get this so wrong? The first thing is that clinicians tend to tell patients what they don't have rather than what they do have. So it's like saying to a patient, well, you don't have Meniere's disease, and then expecting them to be satisfied. It's a common approach, but it leaves the patient wondering what exactly is wrong with them. What about just failing to make a diagnosis altogether? You just, well, I just don't know. Well, then the patient's going to go elsewhere. What about using this lovely phrase, unexplained? And when you tell patients that things like these things are common and we don't know why they happen. So just the next step is, of course, just live with it. Rather make a positive diagnosis. In fact, we do know a lot about functional disorder, and we definitely know how they happen. So why not use a transparent label that's acceptable to the patient? Make an incomplete diagnosis or hiding. So it might be easier to tell a patient that they have migraine, but that still leaves a lot of issues unaddressed, and it reduces the chance of reversibility. What about just saying to them it's psychological? Well, often the link between mind and body is not that apparent to patients, and they're heavily invested in the physical symptoms. So it may not even be relevant to the patient. So from here, it's going to be a very short leap to the patient thinking that you've decided that they are to blame, or not believing that they're not believed at all, or that they're deliberately putting it on. And about 80% of patients are going to reject a diagnosis like this. So let's talk about a better way to do it. What are the kind of things you need to explain? Well, obviously, all patients come to you expecting a diagnosis. So the first thing needs to be to tell them what they do have. So you have triple PD. You have a functional dizziness disorder, whatever you want to call it. And that it's a definite diagnosis that you have made, and it hasn't been a conclusion that you've jumped to, nor has it been a diagnosis that you have made because you can't find anything else. Then explain the mechanisms of the symptom, not the cause. So you need to be talking about how an upset actually changes the way the brain, and note, I often say to the patient, notice I keep saying brain, it hasn't got anything to do with your mind, responds to that combination of incoming signals that contributes to balance. And when that mechanism goes wrong, this is what you end up with. So, as I've said before, how you made the diagnosis. And here I would discuss any positive or inconsistent signs that I found during the examination. This time, after you've made a definite diagnosis, you can exclude anything that the patient was specifically concerned about in the case history. So if they said to you, I think I may have a tumor, I think I may have Meniere's disease, discuss the likelihood of that and that it's very minimal compared to the chance that you are right. I've mentioned this many times before as well. I believe you. Very, very important that the patient is reassured that you have accepted every single one of those symptoms as real, because of course they are real. So what about when you are discussing management and of course the prognosis with patients? You need to stress that because it's a problem about how function is happening, we can change function with work, and that it's a very common and reversible problem. A lot of patients say to me, gee, I thought I was the only person that was suffering like this. And believe me, these patients do describe themselves as suffering. Self-help is important. Patients need to learn how to actively self-manage their condition, the same way as any other chronic illness like hypertension, diabetes. That's really important, that you assist and support and aid patients to step up and self-manage. You need to gently introduce the role of depression, anxiety, and its treatment. And I think particularly with triple PD, we know that SSRIs are incredibly helpful, but if you are going to suggest that the healthcare practitioner prescribes these, then introduce them in a positive light, particularly if the patient has downplayed the contribution of depression and anxiety to their symptoms. So I think that's really important. It's about balancing brain chemicals, right? And that's the only way that you can do it. You can set the patient up for success by making any referrals in a positive, constructive way. So another person that's very good at this particular disorder and understands this disorder is such and such a person. I send a lot of patients to him or her. They see it all the time and they're really, really good. And that's a very powerful thing to do as well. So patients don't feel they're being thrown away, but going to see another healthcare practitioner is another step along the journey towards recovery. Very important also to involve family and friends. I always allow a significant person to come with the patient. They may not be there all the time, but they're certainly there for the feedback, and their contribution and buy-in to both the diagnosis and the management plan is actively encouraged. So that's really important as well. You can't let them hijack the consultation, but you do want them to be along for the ride, as well as giving them written information, and if they have access to the internet, websites that are helpful, and you'll see I've given details of these elsewhere. Prognosis. Now, I think there's an argument to be made for the fact that prognosis could often actually be given even before the diagnosis. And I find it something that certainly my students don't think about that often. And I use an analogy of diagnosing hearing loss in an infant, a profound and irreversible hearing loss, permanent hearing loss. And I often say to them, how do they do it? And they normally say, oh, tell them about test results. Well, yeah, test results are important, but as soon as those diagnostic words are out of your mouth, your child has a permanent irreversible hearing loss, what happens next? Parents go into shutdown mode, they go into panic, fight or flight mode, and they stop listening. Don't you think it might be a better way to say, you know what, it's really good that you've come now, because we've got a fantastic management plan in place for you that's going to give your child every opportunity to progress and make his or her way in life, and this is how we're going to do it. So don't you think that sometimes presenting the prognosis first might be helpful? I think there's a definite argument to be made for that. The other thing I'd like to mention here, that if you give a functional diagnosis in any way different from any other patient, is it worth asking yourself why? So what kind of things can we do to actually prepare patients for successful outcomes for therapy? First thing is, as I've said this before, accept all symptoms at face value and give a positive explanation for them, so patients are sure that you understand. You've got to give the patient a rationale for treatment. If you're making referrals, just why are you doing that? What is going to be the purpose for that referral? What can the patient expect? Encourage activity, and here's the key thing. You've got to explain to the patient that they may feel temporarily worse before they get better, but the benefit is going to be found in the long term. Really, really important. Start with small goals and then build up from there. You don't want to flood patients. This isn't going to work. You've got to give small goals, but ones that the patients still have to manage and exert themselves somewhat to actually achieve and master, and then you're going to build up their confidence from there. Think about things like sleep routine. No patient's ever going to improve if they're chronically sleep deprived, so address that. That's really important. Encourage the patient to reconsider negative or unhelpful thoughts and test out other alternatives to those thoughts, to challenge those negative thoughts. I'm never going to get better, for example. And there's a lot of work now in the literature about the way physiotherapists are actively doing CBT, cognitive behavioral therapy, during their sessions. And this is the great thing about vestibular rehabilitation therapy. You've got that opportunity to just chip away at these kind of issues. Identify and try to manage barriers to recovery. And now, in terms of the prognosis, there was a Cochrane review that found that doing simple things like sending letters to the primary care practitioner, to the GP, suggesting regular follow-up will prevent symptoms of flaring up again. Encouraging a hands-on examination of the complaints and avoidance of repeated tests and referrals actually in the end reduces healthcare costs. So doing it right in the beginning means you don't have to do it again. There is, however, very little research about these steps in terms of patient outcomes or level of function. You need to avoid having the patient walking out your door and thinking that they're this sort of medical mystery or conundrum, and some patients do quite like that. Some patients may not be able to understand or accept their diagnosis and benefit from treatment, and that is just something that we just have to accept. You're not going to be able to help everybody. Some patients are going to reject this outright, no matter how skillfully it's presented to them. And common features, things to look out for of these patients, is they're unable to actually repeat anything back to you about what happened on their first visit, even after a sympathetic first consultation. They may have personality disorders that prevent them from embracing this. They may have fixed views about an alternative diagnosis and just reject anything that doesn't fit in with their worldview or the diagnosis that they have already got in their mind. There may be possible medico, legal or compensation issues, which I've referred to previously. It changes the way patients engage with their illness. The symptoms may be very disabling or long-standing, and these patients we know do less well. The longer it goes on, the more difficult it is to turn them around. It's very important to schedule follow-up visits if you possibly can. This again is a reflection of your attitude. You would follow up any other patient? Why not patients with functional disorders? How many other disorders would you simply diagnose and leave at that? At the second visit, the patient may actually be more open to referrals for management. If the first visit didn't go well, the patient may not have understood or may not be motivated to follow the management plan suggested. Bear in mind we're treating patients when we change a patient's view about their diagnosis in a single consultation. I've already mentioned turning the patients around. And we're well placed to shift any misconceptions about the diagnosis at a follow-up visit. So you might be thinking that this is all very well and sounds all very nice and soft and gentle, but what about the ones that get away? So I'm going to talk a little bit about the pitfalls and misdiagnosing dizzy patients, because obviously everybody's worried about misdiagnosing patients, and particularly in dizziness, unfortunately, is quite frequent. For example, you may miss diagnosing BPPV if you just don't bother doing a Dix-Hallpike maneuver, for example. However, the literature is much more convincing about the lack of misdiagnosis of functional disorders. In other words, if you're making this as a definitive diagnosis, the chances are that it is correct. So this section of the presentation is going to focus on not missing appropriate diagnosis of the dizzy patient. The first mistake that practitioners can make is that you rely too much on the patient's description of the type of dizziness. Remember, often people who've been trained in the traditional approach towards the dizzy patient, the type of dizziness is stressed as the most likely key to point to the cause of the dizziness. And traditionally, these types of dizziness are split into different flavors like vertigo, presyncope, disequilibrium, and then ill-defined symptoms, other kind of symptoms. And each of these categories were thought to have different causes. And the system then often guides management. In other words, if it's vertigo, then there's no need to consider cardiac issues. And so you can see this is very flawed and very limited system. And the problem is that patients aren't often not very reliable in describing their symptom, and the type of symptoms is unable to discriminate among the different causes of dizziness. So it's hugely unhelpful. I've mentioned this in other lessons that many patients change their minds about the description of tinnitus within 5 minutes, and often many patients have more than one sensation. So it gets to be very, very difficult. So we need to go back to our triple TA. So missing the timing and the triggers is going to be more of a hole for you to fall into than not focusing on the type. And this is because the timing and the triggers are often more reliably described by patients and more consistently reported by patients than the type. And certainly the timing can be used to categorize clinical presentation. Certain disorders have hallmark features regarding their timing, and you should be aware of those by now. Be careful of overemphasizing the trigger information, and bear in mind that there's a difference between positioning and postural symptoms. So just a little word of caution there. So what other pitfalls are there for unwary clinicians? Well, the next big one is if you don't understand the eye findings. And eye findings are important in all settings, particularly in the acute setting. So an emergency room type of setting, the outpatient setting where you may be referred somebody who's still very actively symptomatic. However, often patients are seen after the initial presentation, and so they don't have obvious nystagmus unless the fixation is abolished. A good argument to always use Frenzel lenses, of course. Too often, however, nystagmus, if it is noted in the records, it's simply marked down as present, and there's no notes as to the direction, the grade, if it follows Alexander's law, and so it's very difficult for you to look in a folder 6 weeks later and interpret what was seen. So clinicians should understand the rules that govern eye movement so they can identify correctly typical and atypical eye movement findings when they are examining dizzy patients. For instance, conditions like BPPV have absolutely classical presentations which are well defined based on the anatomy and physiology relevant to BPPV. So really important, note-taking needs to be precise and detailed, and the ability of the clinician to correctly induce and interpret nystagmus is very important to avoid misdiagnosis. just recap on the key messages of this presentation. The first is that functional disorders are an everyday occurrence. If you practice, you should be seeing these patients. You should be identifying them and actively managing them. Flags for functional disorders can be found in the case history and often on the examination. The clinical encounter in itself can and must be therapeutic. And finally, you need to know your anatomy, physiology, and pathology to avoid misdiagnosis. And there's just one more slide to go.